So welcome everyone to Geriatric Medicine Grand Rounds. I'm glad you can all join us on a little bit of a cooler day today, so that's nice. But our speaker is a fantastic speaker, and she is in a much hotter place. She's in Dallas, and so we cannot complain too loudly about 90 degrees because she was telling me that it is not uncommon for it to hit over 100 over there. So there we go. But anyway, Dr. Wingfield is a geriatrician and an assistant professor in the Department of Internal Medicine at UT Southwestern. I met her because she was part of the same cohort of GACAs, the Geriatric Academic Career Award, that I was in, and I got to hear about her work over and over during that time when we shared with each other, and I was always very impressed with the collaboration she has built with the surgical specialties, particularly orthopedic surgery and her perioperative work. And I thought it would be of great interest to our group, since we have a longstanding orthogeriatrics co-management service and also some collaboration with other surgical colleagues, such as the burn surgeons and the trauma surgeons, and many others. So I thought it would be very relevant for us, and her work is just phenomenal and really interesting. And she's done a lot over the last several years in particular. She is the director of UT Southwestern's Perioperative Optimization of Senior Health Program, and that's what she's going to spend most of her time talking about today. So thank you so much for joining us, and I'll let you take it from here.
Great. Thank you, Dr. Bennett, for that kind introduction. And thank you so much for having me. I'm really excited especially for the Q&A, for us to talk a little bit about what you guys are doing over there and maybe answer some questions. So to start off with, I have no disclosures, but I did want to acknowledge that I received support through a Geriatric Academic Career Award from the Health Resources and Services Administration for much of the work discussed today. And kind of the outline for what we're going to go through is that, first of all, we'll kind of start off with what's different about the care of older adults in the perioperative period. And I am suspecting that I'll be kind of preaching to the choir about this for the first few slides. Then we're going to talk about the perioperative optimization of senior health model. And then I'm going to kind of describe a little bit about how I brought the model to UT Southwestern. We'll talk a little bit about engaging stakeholders and kind of gaining support and how that happened, a little bit about tracking our outcomes, and some educational initiatives that were kind of put in place over the years. And then we'll also talk a little bit about future directions that I'm hoping to go in. So just to kind of start off with, surgery is common in older people. And so this figure illustrates the nationally representative incidence of major surgery per 100 person years. And the cumulative incidence is about 8.8, meaning there are 8.8 major surgeries per every 100 older adults annually. So basically, 5-year cumulative risk of major surgery is 13.8%, including 12% in patients 85 to 89 years old and 9% in those over the age of 90. So, definitely quite a few of our older adults are undergoing surgery. And you can sort of see in this figure that the rate of elective surgery was higher in those who were kind of in the younger age groups. So here, 75 to 79 was kind of where that elective surgery peaked. Whereas you can sort of see the increase in the proportion of non-elective surgery in really the older patients, and also increase in the proportion of non-elective surgeries for patients who are frail. So frail patients are less likely to kind of have those elective surgeries, and also in patients who have possible dementia. So kind of this figure overall illustrates that surgery is common, even in the most vulnerable subgroups, the oldest old, those with frailty, and probable dementia. And so really, I think it means that we really need to have care processes baked into our healthcare system to address the unique needs of these patients. Also, as again, preaching to the choir, multimorbidity is an issue in our older patients. And so this image depicts kind of relative percentages of older adults with each medical condition who have one medical condition right here in the blue, kind of one or two other medical conditions, 3 medical conditions, and 5 and more other medical conditions. So, kind of to illustrate, right, with heart failure, if you're having over 50% of those patients having 5 or more other conditions in addition to their heart failure. And so when we're operating on older adults, those older adults are also pretty likely to be medically complex. Also, we know that older adults are at increased risk of complications after surgery. So here, you can see that in each decade of age, the risk of having overall major complications, non-cardiac complications, in-hospital mortality, all those things increase with each decade. And in patients aged 80 or older, they stayed in the hospital on average 1 day longer, even after you adjusted for kind of their other clinical data. So, we're operating on vulnerable patients. They've got a lot of medical comorbidities and they're complicated, and they're at increased risk of having adverse outcomes. I also really like to talk about the study from Terry Fried, which I think is kind of an old study, but a good one, talking about the risk of functional and cognitive impairment that really kind of matter to our older patients. And oftentimes older patients are not really counseled on this, prior to surgery. So, the complications that we're likely to counsel them about are things like, what's your risk of mortality? What's your risk of having a cardiac complication? What's your risk of having an anastomotic leak, right? And what exactly does that mean to our geriatric patients? So here you can see if the patient has kind of a low burden, treatment, and it's going to return them to their current level of health, almost 98% of those patients really want to have treatment. Even when you're looking at a high burden treatment like surgery, right? If it's going to return the patient to their current level of health, again, the vast majority of older adults would kind of think, yeah, I do think I would want that treatment. But if we kind of switch that and say that this is a low burden treatment, but it's going to lead to severe functional impairment, then the kind of math switches just a little bit there, and almost 75% of older adults in that situation, they're unsure of whether they really want this treatment. And interestingly, when Terry Fried did this study, she was the alternate to, what she told patients when they were kind of considering these different scenarios was that if you don't receive treatment, you're going to die from your condition. So, patients were saying, even if I'm going to die from my condition, I would rather not receive a low burden treatment that was going to lead to me having severe functional impairment. And again, you can see that same math kind of works out if the patient was going to have severe cognitive impairment as a result. So, these outcomes are really important to older patients, but we oftentimes don't counsel them about these things in the preoperative period. And it turns out that these outcomes that older adults care about, functional impairment, surgery does often precipitate functional decline. So this, and also cognitive decline. So here's kind of a figure from one study sort of looking at, patients who did not have surgery, patients who had surgery without complications is kind of this dotted line here, and then patients who had surgery with complications and their risk of functional decline and cognitive decline. And so you can see that, patients who have surgery and then develop complications afterward are significantly likely. Almost 25% of those patients will have functional decline, 20% of them some cognitive decline. 2/3 of older patients had recovered to pre-surgery level of function 6 months after surgery, in this Bircher study. And that's important because that means a third of those older patients had not recovered to their pre-surgery level of function 6 months later. And we know that intervening illnesses are also really common in that year after major surgery. And if those intervening illnesses lead to hospitalization or an ED visit, that's really strongly associated with adverse functional outcomes. In this Gill study, published in JAMA Network Open in 2020, major surgery increased the risk of having severe disability by 600-fold among previously non-disabled older adults. So, these outcomes that we often don't talk with patients about, are relatively likely, or, a significant proportion, I guess I should say, of patients are likely to have that type of outcome after the procedure. And this is a great study through Vicki Tang's group out at UCSF. And oftentimes, we kind of approach surgery with this kind of fix-it mentality that, we see there's a problem, you've got a tight aortic valve, right? We can open up that aortic valve and we'll fix your problem. But, the goals of the patient might not necessarily align with what that fix would be. So, patients might want to be able to do some valued life activity, right? That might be their goal, and the surgery may or may not get them to that point. So this study just sort of looked at what percentage of older adults were able to perform their valued life activities 6 months after elective surgeries. And so you can see here that a significant proportion of patients were unable to perform IADLs, so almost 20%. And again, almost 20% unable to do valued social activities, even more unable to do valued recreational activities. So, it's really important for us to be thinking about these outcomes that matter to our patients prior to surgery. So I hope that, I sort of have convinced you, and maybe I didn't even need to convince you, that perioperative care of older adults is different. And so we have to have models that really address that. So when we think about traditional preoperative risk assessment, we're thinking usually about assessment of cardiovascular, assessment of pulmonary risk, evaluation and optimization of other medical conditions, for example, diabetes, what's the risk of having infection or, poor wound healing or something like that after surgery as a result of those other medical conditions. Can we get those other medical conditions under better control prior to surgery if they're uncontrolled? Thinking about medications that patients are on and do they need specific management around the time of surgery, and specifically anticoagulants tend to be kind of a sticking point. The geriatric preoperative assessment really includes all of those things and also includes all the things on this slide, which looks a little bit overwhelming. But really, you want to have some evaluation of what's the patient's goals and expectations for the surgery. I think that one of the most dramatic examples that I have of a patient's goals not aligning with what the ultimate surgery would achieve was a patient who thought that a nephrectomy for removal of a renal cell carcinoma was going to cure his urinary incontinence. So, kind of getting a sense of what is the patient hoping for. Making sure that you've evaluated the patient's cognitive status. Do they have the capacity to consent to the procedure if they have cognitive impairment? And what's their risk of postoperative delirium, if they are cognitively impaired? You want to screen for depression because that's associated with adverse outcomes after surgery. Thinking about nutritional status, their current functional status and falls. How will the surgery potentially impact that functional status? And do they have the family and social support to really address those potential functional impairments? Thinking about frailty, as well as the patient's risk for developing postoperative delirium, like we talked about, attempting to do some amount of advanced care planning. Thinking about high-risk medications and management of polypharmacy. And ideally, you're able to do this in a multidisciplinary setting where you can have, the support of your interprofessional team members. So really, as you can see that a lot of this geriatric preoperative assessment is kind of a comprehensive geriatric assessment, to some extent. So the Posh model was initially developed out at Duke, and it is one way to sort of operationalize, getting patients through the time of surgery, hopefully helping to prevent complications. So it's a multidisciplinary collaborative care model between, not only geriatrics, but also anesthesia, also surgery, and really bridges the perioperative period to help these vulnerable older adults get through that period, like I said, as smoothly as possible. So preoperatively, the idea is that the surgeon will see the patient in their clinic. They recognize that the patient's at high risk for postoperative complications, and they refer the patient to the geriatrics clinic for a comprehensive geriatric assessment. And then that visit kind of includes risk assessment for the patient, counseling for the patient, and education for the patient and their family, as well as development of an optimization plan. So if there are things that need to be optimized prior to the surgery, kind of developing that plan ahead of time. Intraoperatively, oftentimes these patients are on enhanced recovery after surgery protocols. The patients actually has the procedure, and then post-operatively, the patients have a proactive inpatient geriatric consult to assist the team with surgical co-management in the post-operative period. And the goal is really help prevent delirium, manage pain, manage other medical conditions, and also assist with kind of that transition between the hospital and the next level of care, whether that be rehab or whether that be a return home. So what to expect, what the Posh visit kind of looks like, we tell all patients, bring a caregiver or a family member, and we'll have a discussion of their goals and expectations for the surgery. I usually start off the visit with, tell me what your surgeon has told you about the procedure, because it sort of starts that visit off with a sense of what is their capacity, how much have they understood so far about the discussions that have been had about the surgery. You always know that the visit is going to be a long and complicated visit when the patient responds, what surgery? And then you'll do a full H&P, making sure that we've got a good sense of what their other medical conditions are and things like that. They get cognitive testing. So in our clinic, what we use is the slums exam, because it's a little bit faster to complete than the MOCA, and we get an hour with the patients. They also get, kind of a discussion of falls. We do a gait assessment. They have a gait speed and a grip strength recorded. We use the frail scale to kind of screen for frailty, nutrition and functional assessment, as well as mood with a PHQ-2 screening and a PHQ-9 if that's positive, and then an evaluation of social support. We do detailed med rec and then counseling about perioperative medications, management, perioperative risk, delirium prevention, nutrition, pain control, what to expect, as well as postoperative recovery. Sometimes this visit also includes kind of a shared decision-making type conversation, because sometimes we'll get referrals from our surgical colleagues really before the final decision for surgery has been made. So they'll say, we're referring this patient for complex surgical decision-making. And so then we'll sort of have some of those discussions about risks versus benefits of the procedure going forward. On the inpatient side, what does our postoperative co-management look like? Like we talked about, management of other medical conditions, monitoring for postoperative complications, delirium prevention, identification and management, pain management, a focus on their nutrition and their mobility in the hospital, and addressing things that might be preventing them from eating and drinking well or working with physical therapy, management of constipation and urinary retention, and then those transitions of care. So the Duke Posh program, this is kind of their published outcomes, looking at elective abdominal surgeries. And even though Posh patients were on average slightly older and slightly sicker than historical controls, patients who went through the Posh program stayed in the hospital almost 2 days less. You can kind of see here. And they were less likely to be readmitted at 7 days and 30 days, and they were more likely to be discharged home with self-care. So, those are kind of some of the benefits of the program that we wanted to bring to UT Southwestern. So kind of starting off with, how did we do that? How did we bring the Posh model to UT Southwestern? I think that one of the first things that was really important about this was really kind of gathering that interdisciplinary team, multidisciplinary team. And so we had a neurosurgery champion, one of our neurosurgeons, and he was the director of our multidisciplinary spine clinic. And so he was kind of invested at the beginning and kind of helping the program to get off the ground. And we also identified an anesthesia champion as well, who was the director of our pre-surgery clinic, our surgery anesthesia clinic. So some of the challenges that kind of, arose right at the beginning was, how are we going to get these patients seen? And the workflow, our geriatrics clinic is primarily a primary care clinic. So we really don't have a large consultative volume. And so the workflow of primary care for the clinic staff was really pretty different than the workflow that was necessary for Posh. And it was really, our primary care clinic, for example, only sees people over the age of 80 just because of, space constraints and, our inability to handle a volume of everyone over the age of 65. So there was a lot of confusion sometimes with the schedulers, like, wait, this patient is 65, they're not allowed to be seen in geriatrics. But it was like, no, for a consultation, they're allowed to come and be seen. Also, pre-op assessment at UT Southwestern was a little bit complicated. So our surgery testing clinic for anesthesia is located at the hospital. And not every patient was seen in that pre-surgery testing clinic. It was kind of up to the discretion of the surgeon whether they would go there. And there was really no other infrastructure at all. Our campus is very large and spread out, so that was kind of a challenge. And there was going to be a change to surgery clinic workflow to bring this model here. So a lot of the surgeons said, well, this is great, I would love to have this, but how am I going to remember which patients are appropriate to send? How am I going to get this to happen? And we had no inpatient geriatric consult service, so we had no one to see patients on the inpatient side. So kind of to address those challenges, I started to see these patients for preoperative assessment in the geriatrics clinic. And we started with just our neurosurgery champion, like sending his patients to me preoperatively. So I would see maybe 1 or 2 patients a week for him. And then we had to educate the clinic staff, kind of regarding the workflow. They had to be educated about how to take a gait speed, how to take a grip strength, about our schedulers had to know, well, why is this preoperative assessment different? We also have an internal medicine pre-op clinic, and sometimes they would want to just schedule patients in either a geriatrics pre-op slot or an internal medicine pre-op slot. And we had to say no if they're referred to us, they're getting a very specific assessment. We had to have a tight collaboration with anesthesia to make sure that if patients were going to go to the pre-surgery testing clinic, they were also going to come to Posh, and hopefully on the same day, so that our geriatric patients aren't having to come multiple times to the medical center. And we developed a best practice advisory in our electronic medical record. And so I'll show an example of that to help with this issue of the surgery clinic workflow and help to remind the surgeons of when a patient might be appropriate to send. And then we obtained health system buy-in to help us to get the inpatient geriatric consult service off the ground. So the best practice advisory, we wanted to use the electronic medical record to really prompt the surgeons to when a patient might be appropriate for a Posh clinic referral. And so how this works is when when the surgeon puts in a surgical case request, the electronic medical record will identify if the patient meets criteria for referral. So these were the criteria we picked, kind of based on, patient or some things that would indicate that the patient might be at higher risk. And also kind of based a little bit on the Duke Posh referral criteria as well. So age over 85, just hands down, and anyone with age over 70 with any of the following things. So known or suspected cognitive impairment, our EMR will identify, do they have memory loss listed on their problem list? Do they have a prescription for donepezil? For example, greater than 3 chronic medical conditions, greater than 5 medications, or BMI less than 25. I wanted to have weight loss of 10 pounds or more in a year, but apparently Epic is unable to subtract. ChatGPT can pass the boards, but Epic can't subtract. So this is what the best practice advisory looks like. When that surgeon puts in that case request, it will tell the surgeon your patient meets criteria to participate in the Posh program, and it kind of describes a little bit about what the program is for. And then they can either order it or they can not order the Posh referral. And so, it's not a hard stop. They can just say, nope, I don't want it. And then it goes away. So kind of the benefits of this best practice advisory was, number one, it prompted the surgical team to think about whether the referral was appropriate, as well as it could tag patients who met the criteria But the surgeon said, no, I don't want to refer them. And so that assisted us with tracking outcomes. And I'll kind of show you how we did that in the next few slides. It also helped with planning for program growth, because in order for the patient, for a surgical group to have the best practice advisory activated, they would agree to it. And we could sort of say, okay, the spine clinic wants to have this activated for all of their patients, and our EPIC team could run the best practice advisory in the background and tell us about how many patients will meet criteria. So we could start to think about, well, how much, space do we need to have on the outpatient side to start to see these people? Talking a little bit about engaging stakeholders, I talked about our neurosurgery champion and our anesthesia champion, but also we reached out to our surgeons who were interested in quality improvement. So I kind of started with our NESQIP champions, and then kind of just took the show on the road, speaking to different surgical groups, talking about, what I thought we could offer and that kind of thing, as well as speaking with the hospital administration. So I was able to provide them with data regarding the program effectiveness at Duke. And I had that specific ask of saying, what we really need on the inpatient side is a nurse practitioner or a PA, so kind of an APP, to be on the service all of the time. We run our consult service Monday through Friday, so Monday through Friday throughout the year, and then our attendings can rotate on and off. And then also having the importance of kind of tracking outcomes. That was the hospital administration wanted to see that we were, kind of achieving some of those things that we thought we could achieve. So in order to track outcomes, we developed this Microsoft Power BI dashboard. And so it tracks length of stay, variable direct cost, discharge disposition, and now recently we've added delirium rates as well. And then it also kind of tracks consult volume and stats on the best practice advisory. So it'll tell us, which percentage of patients are we bypassing the best practice advisory on, for example. So this is kind of what that Power BI dashboard sort of looks like. So this is looking at one specific surgeon. We can look at kind of the surgery date for the fiscal years. We can look at which type of surgery people were having. So this is looking at inpatient procedures. These are our Posh providers. So the non-Posh provider, what this means is people who met our referral criteria, who did not come to see us. And then these are kind of all of our Posh people. And so you can see that people who had similar surgeries with this surgeon, they were staying in the hospital about 7.6 days. And our Posh patients are staying in the hospital about 5 days. This is a spine surgeon. So kind of, and does complex spine surgeries, fusions and things like that. And then we also have looked at, so we kind of published some of these outcomes in the Journal of the American Geriatric Society. We did a study looking at delirium rates in our Posh patients. Our spine surgeons, since neurosurgery was our initial group of champions, that's the group we have the most data on. So what we did was we looked at, again, people who went through the Posh program compared to historical controls. Again, our Posh patients were slightly older and slightly sicker. They had more medical comorbidities than historical controls. How we looked at delirium was that we used Sharon Anyway's kind of chart method of like looking for delirium, because initially we didn't have kind of a standardized screening protocol. But you can see here, so kind of aggregate, this is all spine surgeries, Posh group compared to historical controls. Delirium rates are lower in the Posh group and it kind of approaches statistical significance. But if we specifically look at patients that were having greater than 4 levels of spinal fusion, so patients undergoing complex spine surgery, our Posh patients had about a 12% delirium rate, and historical controls had about a 29% delirium rate. And so here, you can sort of see those cumulative costs that are attributable to delirium based on the literature. And so, we can kind of go to our health system and sort of say, like, look, we're preventing delirium. We're saving a significant amount of money. Now I'm going to talk a little bit about some educational initiatives that we have put in place through our Posh program, because I do think that the Posh program is an ideal place to educate people about geriatrics. And so, again, a lot of this work was supported by my Geriatric Academic Career Award from HRSA. And it's a great place for interprofessional education. We're addressing a lot of different, I guess, domains, right, for the patients. And so we have interprofessional learners in our Posh clinic, as well as on our inpatient geriatric consult service now. So that just started, at the beginning of my GACA about 4 years ago. And then as well, we have educated the nurses on our postoperative floors about delirium and instituted kind of a protocol for them to screen in a systematic way. For postoperative delirium. And then also we've done some surgeon education initiatives as well. So as I mentioned, the Posh clinic and the inpatient geriatric consult service have become clinical rotations for interprofessional learners. So we've had internal medicine residents, we have psychiatry residents, PA students, pharmacy students and residents, as well as medical students, and our geriatric medicine fellows kind of rotate through these clinical sites. And like I was mentioning, I really think that the Posh clinic is kind of an ideal place to learn about comprehensive geriatric assessment. They get to kind of get a sense of, frailty, and they get a sense of polypharmacy, all those things that we really care about in the geriatrics world. Our inpatient geriatrics consult service also provides our internal medicine residents and the experience of acting as a general medicine consultant to a primary surgical team. We don't have a general medicine consult service that the residents rotate on. So this gives them that experience as well. And during their rotation, they get education about delirium and delirium prevention, pain control in older adults. This can kind of obviously become an issue if we're dealing with people with cognitive impairment. And then hazards of hospitalization, kind of failure to thrive, is another issue that we commonly deal with kind of in that postoperative period. And we have kind of some of our most difficult perioperative cases that have come through the Posh program that we can kind of discuss with our learners to sort of illustrate, the reasons why geriatric perioperative care is different. Our nurse education. So we have kind of initiated education for the nurses on the postoperative floors about delirium and delirium prevention. And our nurses were then trained to screen for delirium using the 4AT and record their results in the electronic medical record. So we started this initiative with our postoperative neurosurgery floor. You can see kind of the difference in knowledge of the nurses about delirium. And, this was kind of statistically significant. And now we started with our postoperative neurosurgery floor, but we've combined efforts with our geriatric nursing committee, which is kind of hospital wide. Each floor sends a geriatric nurse champion to a monthly meeting to discuss different geriatric initiatives throughout the hospital. And that committee has helped us to sort of spread the 4AT screening throughout our university hospital. Again, we developed a Power BI dashboard to track delirium screening rates and delirium rates on each floor. And then this kind of allows us to identify floors that need re-education, about, the 4AT or, kind of implementing that screening. So kind of a picture of an example of this. I used our geriatric floor as our example, just because, you can see very high screening rates. So 12 Blue is our ACE unit. They've been screening for delirium for almost a decade now. But here you could sort of see that, their screening rates are pretty high, 100% most months. And this is 100% of the patients kind of receiving 4AT screening during their hospital stay. And this very low number is 94. So they're getting, the vast majority of the patients. And then we can also track delirium rates. So which percentage of patients had a positive 4AT during their hospital stay. And here you can see that it kind of tracks with the literature. So what we know about, kind of delirium on a medical floor, again, this is our ACE unit. So, ranges from about 20% to almost 40%, which is kind of what we would expect, like I said, based on delirium literature. And so we can track this for every floor in the hospital. You can see that's over here on the left side, and we can sort of say, the one floor we're kind of focusing on is our neurology floor right now, and kind of trying to identify, what are the barriers, to kind of recording their screenings. As far as surgeon education goes, we developed lectures for neurosurgery and orthopedics residents who are rotating on their spine rotations. And so, delivered these lectures about preoperative assessment, frailty, polypharmacy, delirium, to really, hopefully, kind of educate them about these issues. And then we also, so one of our orthopedic surgeons, we partner together really closely. And so this surgeon and I give lectures to the orthopedics residents about hip fracture, as well as preoperative assessment for patients undergoing more elective orthopedic surgeries. And we have also had delirium as a complication that's kind of discussed in our surgical morbidity and mortality conferences. Also, we started this annual combined Division of Geriatrics and Department of Surgery Grand Rounds, and we initiated this in 2018. So we're now in our 7th year. This year will be our 7th year of having a visiting professor come speak. The goal of this session is to, again, kind of really identify the unique aspects of caring for older adults in the perioperative period. And so we first had Dr. Tom Robinson, who is from University of Colorado, give our first combined grand rounds. And initially, this was all supported financially by the Division of Geriatrics, but now it is supported half and half. So the Department of Surgery supports half of the visit, and the Geriatrics Division supports the other half of the visit. So some future directions that I'm sort of looking forward to is this idea of really so one of the things that's a challenge is that how do we as geriatricians, being such a small group, really impact the care of all older adults who are having surgery, right? It's impossible for me and a small cohort of geriatricians to really see every single older adult who's going to have an elective surgery at UT Southwestern. And so I think that one of the ways for us to kind of bake these geriatric care processes into the healthcare system is maybe through something like the Geriatric Surgery Verification Program through the American College of Surgeons, where you have where your electronic medical record really supports these care processes for older patients. And so I think that is kind of one future direction is, while that maybe the most high risk people come to a Posh type program, and you can identify those people initially prior to surgery, then every other older adult also receives geriatric friendly care processes. And I think that the geriatric programs as well, the age-friendly health systems also, sort of helps with this. So, that's one area where I think we're heading. Research collaboration. So, our Posh program, I think that we are looking at collaborating with the surgeons, looking at outcomes in different types of surgeries, cystectomy and Whipple and things like that. And, I think that anytime you have a program, challenges always pop up that you weren't necessarily expecting. So, we have had kind of turnover of not only our staff, but also surgical staff. And so kind of going around and kind of discussing with new faculty members, as well as, new nursing staff and things like that, what the program is about, how we can help, that kind of thing. So, you're constantly having to reassess where you're at. One of the other things that, it's not necessarily Posh, but another kind of collaboration that our geriatrics division has been working on. And, Dr. Bennett was talking about your collaboration with orthopedic surgery. And, we also have kind of collaborated with orthopedic surgery over the last 3 years or so. Dr. Megan Sorich is one of our orthopedic surgeons here, and she's completed an ortho geriatric trauma fellowship. And so she has started this program called the Restore program. So returning seniors to orthopedic excellence. And basically this is a multidisciplinary program to help care for older adults with hip fracture. And so they have kind of a pathway, someone comes in with suspected hip fracture, they very quickly get an x-ray, they very quickly get an orthopedics consult. The goal is to get these patients to surgery within 24 hours. They're admitted to our medicine hospitalist service, but there is a geriatric consult on all older adults with hip fracture. And so what we do during that consult is really think about, is this patient delirious? How can we prevent delirium if they're not? Again, thinking about post-operative pain control, talking about osteoporosis and looking at the reason for the initial fall. How can we prevent future falls? As well as kind of a discussion about advanced care planning. Like, we're hoping you're going to recover from this insult, but what if you don't? And so just recently this program kind of achieved disease specific certification for hip fracture through the Joint Commission. So we've been kind of proud of that collaboration. Mhm. So a few take-home points. So geriatric patients really require special care and attention in the perioperative period. And the Posh model is one model of care that's really designed to improve the care of older adults undergoing elective surgery. I think that one of kind of my take-homes from all of this is really that when trying to start a new geriatric program, it's really important to kind of gain that support of stakeholders, determine your specific ask, what can they do to help you, and then have some way to track outcomes in order to demonstrate that return on investment, so that everybody is kind of on the same page about how beneficial your program is. Some of my acknowledgements, Dr. Craig Rubin is our division chief, as well as the rest of the division of geriatric medicine, who are all kind of my partners in crime. Our nurse practitioner who is on our consult service, who really has become the face of that service and really embraced, promoting this program throughout the hospital. Our ACE unit and our niche staff, who has helped to spread some of these educational initiatives. And Dr. Nick Pernick and Paul Vashademi were two medical students who kind of worked with me on a lot of the delirium data that I mentioned. The Duke Posh team, who sort of helped us to sort of get things started here, as well as the Health Resources and Services Administration for their support, and my 3 boys who, tolerate me, working and, being passionate about my care of older adults. I'm happy to take any questions or comments, that you guys might have, and thank you so much for having me.
Thank you so much, Dr. Wingfield. That was fantastic. You covered quite a bit, and it's really wonderful to hear about your program and all of the future directions. That's great, and it's wonderful that you shared outcomes. There are some questions that popped up in the chat, and I'll read some of those, but if folks also have questions that they want to unmute to ask, you're welcome to do that. I'll start from the top here. Amy Thomas is wondering how you chose the cognitive screener that you use, particularly wondering why you chose the slums over something like the mini cog.
And so I think that the mini cog I do use that, on somebody who, for example, relatively, let's say that they're 65, they're going to have a knee replacement, no major concerns about their cognition, and their mini cogs 5 out of 5, then we don't kind of go down that more detailed cognitive route. But for most of our patients, we're using the slums, and I think that it gives you a better sense of maybe some different domains where people might be having difficulty, because the mini cog you're really only looking at executive function and memory. So, I think it gives you a sense there. I do think that there are some issues with the slums, things like, is it culturally relevant for some patients? If you have language barriers, that's kind of a problem. So in those patients, we don't tend to use it. People who you're concerned about, language barriers, I tend to use the mini cog. But the reason it's not the MOCA or some other screening test is just like I kind of mentioned this, we have 1 hour to see these patients in the clinic, and there's many issues we've got to address, and it slums is a little bit quicker to do.
Great. The next question is from Kay Ritchie. She's wondering how you have discussions about patient priorities and expectations, and how you and your clinic has navigated times when a surgical pause seems appropriate with both the patient and the surgical team.
Yeah. So I think that one of the challenges with the clinic sometimes is that patients oftentimes perceive us as like this barrier to surgery. And so we've tried to kind of, reframe that for the patients. And we've given our schedulers even a kind of a like a script to go over with the patients. Like the goal of this visit is to optimize you for surgery. It's not to be a barrier to you having surgery, because they'll be like, did I pass? Right. And you're like, no, that's not the point. um, so, and that's how we've sort of framed things with our surgeons as well, as like, we're not here to be a wall to you doing surgery. And I would say that the number of patients that I've said absolutely no to proceeding with surgery is probably, I could probably count them on one hand, and I've been doing this is now my 7th year, at UT Southwestern on faculty. So, we very rarely say absolutely no. So I think that one thing that helps with sort of that surgical pause is like just developing those relationships, because then the surgeons know like you're not trying to be a barrier to surgery, and they know that if you're concerned, then there's a reason to be concerned. And so, really developing those relationships, I think, is really important. And so I address with patients, I'll sort of say like, look, we want you to have this surgery go as smoothly as possible. I'm really concerned about X, Y, Z. I think if we address this prior to surgery, you're going to have a better outcome afterward. And I would like to discuss with your surgeon too, but I think that this is going to be the best route going forward. And a lot of times patients are amenable. Not all the time, but a lot of times.
Great, thank you. That makes a lot of sense to me. The other question that Key Ritchie had is if you have a middle range referral pathway, so people who might not qualify for the full assessment in your clinic, but might benefit from rehabilitation or optimizing nutrition.
So we don't at the moment really have that. I mean, I'd say that the closest place that we are to having that is in our cancer center. So our cancer center, we have a cancer rehab program with PM&R. One of our PM&R physicians is running that. And then also they have quite access to a lot of nutritional services. So some of those patients are able to access, kind of rehabilitation and nutrition services. But we don't really have like a middle range right now. And again, I'm kind of hoping that in the future, we sort of have that ability to sort of provide geriatric friendly care to more people, even people who maybe don't need the full thing,
Great. There's also a question about whether social work is involved in the Posh team and or the surgical team.
Yeah, so we do have a social worker in our clinic, and she is involved. We involve not on every single patient because she also supports our primary care clinic, and so she's very busy. So we involve her on the patients who, have the geriatrician has identified as maybe having the most vulnerability. So we've had patients, some patients with housing issues, for example, or if we're trying to identify a surrogate decision maker and it's really hard to do so. Those types of things. I was going to say, and on the inpatient side, all of our patients see our social workers on the floors, but we don't have like our consult service really isn't like a mobile ACE model, I guess, where we have like kind of our own interdisciplinary team. The patients that we're seeing have, the physical therapist on the floor, the social worker on the floor, and then our geriatrics team, kind of consists of learners usually, and then the geriatrician, as well as, some pharmacy students and residents sometimes. But so we don't have, kind of mobile ACE model, I guess.
Great. Yeah, there are a lot of challenges in setting that up. But your model is awesome. Mary Zeitner, who is a physician assistant, talked about how they had a model similar to this at a hospital she worked on, and how it sounds like it was a little bit of an uphill battle to to get this added to the assessment. So thanks for sharing that, Mary. And Sophia Jaramillo is asking how you handle personnel rotating, and, training new hires, how you deal with turnover of folks that are involved in these patients' care.
Yeah, this is a great question. And actually one of the biggest challenges, I think that, one of the most important team members, I think, is our schedulers, and just because oftentimes it's much more complicated than scheduling kind of a primary care visit, in that they've got to look for when is the surgical date. We like to see the patients at least 2 weeks before the surgical date, if possible. So they've got to look for when's the surgical date, when should we see this patient, also coordinate our visit with the anesthesia visit, so the pre-surgery testing visit. If the pre-surgery testing visit isn't on a day that we have available, oftentimes they're more flexible, so the scheduler will have to reach out to pre-surgery testing and coordinate that. It's much more complicated than dealing with scheduling kind of a primary care visit. And so when we have had turnover of that staff, it has been really very hard on the program. Things like the wheels start to fall off the apple cart like really quickly. So we have developed, kind of like I mentioned, kind of a onboarding of, we meet, we talk about why is this program important? How is it different? I have developed like kind of scheduling flow sheets, for our scheduling assistants, as well as, like I mentioned, kind of a script to read to the patients. So, when they call, because that's another challenge, is sometimes the patients don't know why can't I just see my primary care doctor for a preoperative visit like I always have. So that's sometimes the challenge too. So kind of explaining why is this evaluation different. So as far as other staff, we've actually been reasonably steady, in our geriatric, faculty staff. So, when we have new people come on who maybe haven't done a lot of these preoperative assessments, we've had them kind of shadow, follow me in clinic and kind of see how a visit goes. And we also have monthly meetings of our Posh team to sort of talk through difficult cases. That's kind of oftentimes one of the most challenging things, is how do I deal with communication back with the surgical team, about concerns that I have or whatever.
Right. And Sophia also changed your language of partners in crime to partners in shine, which I like, because you're doing great work.
Oh, I like that too.
May Reed is asking if you are using prehab bundles with the patients prior to their surgery.
So one of the things that's very challenging, I think, and where our like payment models maybe haven't really caught up, is, this idea of prehab. So, from the standpoint of getting people nutrition services, that can actually be really difficult, just because, really Medicare pays for nutrition services in like really limited circumstances. And same thing with physical therapy. If the patient already kind of needs physical therapy to begin with, then you can get them that service. But otherwise it's really difficult to get that paid for. Certainly, so like I was mentioning with our cancer center, because those patients do have access to some of those services, it's much easier to sort of get them the services that they need. But, I think that prehab is still an area of, I would like to see grow and be better.
Great. Those are the questions in the chat. Does anyone else have questions they want to unmute and ask? Thank you for answering so many questions.
Of
Yeah,
course.
I'll unmute myself. Thank you for speaking all of my questions, Kate, for me. I appreciate it. Thank you for this wonderful talk. We're actually trying to model some aspects of this at VA Puget Sound right now. We're collaborating with one of our hospitalist colleagues who actually approached us about doing this. And the VA has the REI. I don't know if you're familiar with the REI screener. Analysis. Yeah, we're utilizing that because it's kind of the VA way. But irregardless, I learned a lot from all the challenges. And one of the things I'm curious is, it sounded like you got support from leadership to like help establish FTE, maybe physical space, all the above. Was that already like preset, or did you have to make a kind of a request or show that this was important, that everyone should believe in this?
Yeah, so I would say that hospital leadership has been really helpful in supporting our inpatient APP. So that was kind of the primary place where they supported some FTEs for that. And then also in some of the data tracking, like, so basically, kind of giving data analysts to help build those Power BI dashboards and stuff, because they were invested in like seeing those outcomes. I think that, I had to kind of make a pitch to them. And I kind of started with our quality office, like, hey, I think this would help improve some of the quality of care for our geriatric patients. And, here's the data from, what Duke was able to accomplish. I think we could accomplish the same thing here, and then, then the quality office was able to get me in contact with who would be able to, kind of make those decisions. And so
did you use like your NSQIP? Like we have VSQIP, so the VA, but it was like, did you use that as a point of contention? Like, oh, look, this is how we're doing on these various VSQIP measures, or the morbidity or mortality. I'm just curious.
No, I didn't at the time. I just kind of was like, here's the benefits of a Posh program, but I think that would be a really effective way of doing it. Like if there is a specific, concern, with your quality data, and then you could say, I think we could address this specific concern, and especially if like what the hospital leadership is concerned about, that always really helps too.
Thank you.
Yeah, of course.
Great. We might have time for one more question if anyone has a burning question.
This is, okay, it's not burning.
It's okay.
Any question, that's fine, May.
No, I was just thinking about prehab bundles, yes, and the cost. This is a big area of interest. We don't do elective pre-ops. The geriatric service here at Harborview is strictly the trauma acute population, but the anesthesia pre-op clinic and many of our anesthesia colleagues are looking into this very aggressively, and it's crazy that there's no funding mechanism. So, but maybe you could just talk a little bit about what prehab bundles are for the audience that doesn't know, Dr. Wingfield.
Yeah, I think that, so there's a bunch of different, potential options, and I don't know that anyone has really identified like this is the perfect prehab bundle, but definitely like out at, for an example of one program that maybe does some of this is like Michigan kind of had like a preoperative surgical clinic where you would talk about, nutrition, optimizing nutrition prior to surgery, optimizing, giving people exercises and things like that to complete prior to surgery. Also discussing like mindfulness, and dealing with preoperative anxiety. And so, these types of prehab bundles, other places have implemented. We did have a kind of a similar program here called the MAX program. And then it went for a few years and then didn't continue. Those are kind of what a lot of places have looked at as far as, nutrition optimization, optimization of physical, function prior to surgery, and then also addressing anxiety that people have prior to a surgical procedure. I don't know if that was what you were thinking about, Dr. Reed.
So many, and my anesthesia colleagues who, again, several are out of town and are sorry to miss this. We're talking about now that there's cognitive prehab bundles. So you're right. There's just so many. None of them are funded. Some of them can be kind of snuck in, like you can hand the patient some stretch band, resistance bands, and an incentive spirometer and your own. But yes, there is no actual funding pathway, which I think is, I bet someone will find a way to get Medicare to cover it.
I hope so.
Great. Well, we're at 9:00 our time, so we're gonna wrap up. I imagine if folks have other questions that they could reach out to you with those.
Yes, please feel free.
Much appreciated. Really appreciate the time you took to share the wonderful work you've done with us and answer a lot of questions that we had and answered them so well. It was really great to have you with us here this morning, and look forward to hearing more about all of the awesome things that you're doing.
Oh, thank you so much. I really enjoyed it. Thank you for having me.
All right, everyone. Well, have a good rest of your Friday.
Thank
Thanks
you.
for joining us.